Be speaking on the staining of ocular surface and color-coded corneal diagram. So whenever we say ocular surface, in general, what do you think? We are talking about what? Anyone? We are talking about, in general, we are talking about corneal epithelium, we are talking about conjunctival epithelium, and we are talking about tear film. Okay, these are the three main important things. Okay, but apart from these things, you will have to pay attention to other components as well, because it's a system. So what things you will have to keep in mind? Roots of eyelashes and associated glands, NLD, and last but not the least, blink reflex. Because all these components, they work together to keep the ocular surface healthy. Now the question comes, why we want to stain? Because you all know it is an inexpensive diagnostic tool to evaluate the integrity of ocular surface, right? Second, whenever you stain the ocular surface, it gives us some additional information, so it helps us to diagnose as well as to prognosticate the ocular surface disorder, right? And when you start your treatment, during follow-up, if you keep staining your patient, you can see whether your treatment is responding or not. Okay, so these things you will have to keep in mind. Now next, there are three vital dyes which you use to stain ocular surface, out of which the fluorescent dye is the most commonly used dye since 19th century. Okay, so it was von Baer in 1871 who first synthesized it from phthalic anhydride and resorcinol. But actually it was M. Straub in 1888 who used fluorescent dye for the first time for the vital staining of eye. Okay, so these two people you should always remember. So the most common form in which we use fluorescent dye is single-use fluorescent impregnated strip. Okay, and each strip contains 1 milligram of fluorescent sodium. So what is the mechanism of action? Fluorescent actually absorbs light in blue spectra, and that's why we use blue filter for excitation. So when it gets excited, it emits yellow-green fluorescence, and that you can see through blue filter also. But if you really want to enhance fluorescence, you will have to place yellow filter in front of the eyepiece. Okay, so what this yellow filter will do? Actually, some blue light is also emitted along with green light, and this yellow filter knocks out all the blue light, only allows yellow light to pass. So that's how the green fluorescence stands out, and you can pick up very subtle changes. Okay, now this slide is having two figures. Figure A showing fluorescence, the upper one, the fluorescence of inferior meniscus along with the increasing concentration of dye. Okay, and in the lower figure you see a graph. Here on the y-axis there is intensity of fluorescence with concentration of dye. So if you see here, if we increase the concentration of dye up to a certain concentration, fluorescence increases. Okay, and at this concentration 0.15%, we get maximum fluorescence. But if you see after this, if you increase the concentration of dye, fluorescence decreases. Why this is happening? Actually, there are so many molecules on the surface, so many molecules of fluorescent dye on the surface. And the wavelengths which are emitted from some molecule, they are absorbed by other molecules. So final intensity reduces. So what do we mean to say? We mean to say that if we want really good fluorescence on the surface, we should dye in appropriate concentration, and that is 0.15%. Okay, so this is the message, and this phenomena is known as quenching phenomena, concentration quenching phenomena. Because of that, the fluorescence decreases. Now, another dye is rose Bengal dye. It is the derivative of fluorescein. It is also most commonly used in the form of a strip, and each strip contains 1.5 milligram of rose Bengal dye. It is also water soluble, but it stains dead and devitalized tissue. So whenever we suspect damage to the conjunctiva or corneal cells, we use this dye. It also stains mucous threads and corneal filaments. We use only white light to examine whenever we stain ocular surface with rose Bengal. We don't need cobalt blue filter, okay? But this dye is having so many side effects. So most of the ocular surface surgeons now they prefer lissamine green dye over rose Bengal dye. Now, here is a small video showing how you should use fluorescent dye. So after putting a drop of paracaine or sterile saline, just shake it to remove extra fluorescein. Ask your patient to look upward, place it gently on the bulbar conjunctiva, ask your patient to blink for a few times, and then you can examine the ocular surface under cobalt blue filter. Now let's come to the uses of ocular surface staining. So the first use is in corneal infections. So like in this case, I have shown you a case of corneal ulcer. So on day 1, we stained the cornea with fluorescent dye. For what? For documentation, okay? And then during follow-up, you see, I kept on staining my patient to see whether my treatment is, good or not, patient is responding to my treatment or not. And you can see within a period of 18-20 days, the ulcer was completely healed and the cornea became stain negative. But in cases of herpetic keratitis, we use 2 stains. And what are those stains? Rose Bengal staining for viral laden cell. This is rose Bengal staining for viral laden cell of dendritic ulcer, and bed of the ulcer is stained with fluorescent dye. And you can see again during follow-up, I stained my patient and within 18 days, it was completely healed. Stain negative, rose Bengal stain negative. Here also. Yes, you can see some punctate staining over here because of not so good ocular surface. But actually ulcer was healed. Okay. Now, the next use of ocular surface staining is in ocular burns. So, whenever you see a case of chemical injury, ocular burns, thermal burns, you should stain your patient with fluorescent dye. Why? Anyone? Why we do this? To assess the damage, the amount of damage to the ocular surface. This is the only way. Okay? And because on this basis, we plan our treatment. So just see, this was a case of 16-year-old girl. She got tuna injury and we stained her after first aid. We stained her with fluorescent dye and you can see there was 3 to 4 clock hour limbus involvement and 10% of conjunctiva is involved. Why we are so much interested in limbus only? Why I'm not saying this much cornea is involved? I'm not saying this much cornea, 80% cornea is gone. I'm saying only 3 to 2 clock hours here, 2 clock hours here. So I'm saying only 4 clock hours limbus was involved in this case. Why? Why I'm so concerned with limbus? Anyone? Yes, because we are concerned with limbal stem cells. If they are healthy, because at rest of the places they are healthy, that they will take care of. So after staining this, we thought, okay, we can go ahead with the medical treatment in this case. We didn't do any amniotic membrane transplantation at that time. And you can see within period of 15-20 days, her ocular surface has become much, much stable. Okay. Now the third use is in OSSN. What is OSSN? Okay, ocular surface squamous neoplasia. Why we stain here? We have used rose Bengal stain here to delineate the area of involvement. You can see here, if you can make out, apart from these main areas, there is one small patch over here, if you can make out, of with rose Bengal staining. And these things are very important if we are planning any surgery, because during surgery you will have to include all these areas. Okay. Now, the most important use of ocular surface staining is in dry eye evaluation. And here is the practical sequence of dry eye test. So first you should measure the tear film breakup time, first thing. Then you can do the assessment of corneal and conjunctival staining with these dyes. Actually, there is no particular order in which you should use these dyes, but normally it's a general practice that we use fluorescent first, then either Lissamine or Rose Bengal. Then you can go ahead with Shermer's and other tests. So this is again a small video how you should do or how should you measure the tear film breakup time. So after staining the ocular surface with fluorescent dye, ask your patient to blink for a few times, then ask patient not to blink. And the appearance of first dry spot is the measure of tear film breakup time. Can you make out these dry spots? Can you make out? Is it visible? Okay. So in this case, it was 6 seconds, and it means the tear film breakup time is marginal. Now another one, if you see carefully, so these are the dry spots. Okay, so here in this case it was 3 seconds. So in this case the tear film breakup time was low, and you will have to repeat these test at least for 3 times, then you take average of it. Now let's come to assessment of corneal staining and conjunctival staining. So whether you are using VBS or OSS, one thing you should always keep in mind that for cornea we use fluorescent dye, and for conjunctiva we use Lissamine green dye. Okay, and then depending on the number of dots you can give a score. So for the whole ocular surface the score would be 9. Okay, 3 for cornea maximum score, and 3 here for the nasal conjunctiva and the temporal one, 9. And if any of these are present, okay, if any of these is present over there, they keep on adding +1 for each of these, and then final score would be 12. Now this slide I put deliberately just to make you understand how we assess the dry eye case. So this one. Yes, this one. So you can see for the cornea I have used fluorescent dye, and this is the typical staining pattern of dry eye involving the interpalpebral area. And if you count the dots over here, they are more than 30. So what would be the score for this cornea? 3. Okay, and for conjunctiva we have used Lissamine green dye, and you can see intense staining over here. And always remember, Lissamine does not stain any normal ocular surface. So here the ocular surface is not healthy. So here the intense patch, the score would be 3 near about. Here also, if you can make out, there are dots. Here you can also see in this conjunctival part, staining is pretty intense, and here also. So score would be for this case near about 12. Another case of dry eye post Stevens-Johnson syndrome, and this is the typical staining pattern of the cornea in SJS, because of here you can see the concentration of dye involving the inferior 1/3 of the cornea and superior 1/3 of the cornea. That is because of lid viper epitheliopathy. So now another use of ocular surface staining in the detection of occult perforation and leaking blebs with the help of Siddle's test, and last in the contact lens fitting. So now I am coming to the second part of my talk, and that is color-coded corneal drawing. So the drawing in ophthalmology started way back in 1969 with Shepins, and it was Braun A.J. et al. Who started corneal drawing for the first time, and they published their work in 1973. But actually it was Waring Geo who developed the systemic method for corneal drawing corneal pathology. So these two people you should always remember. Now again the question, why should we learn it? Because as a postgraduate student, whenever you get a case of corneal ulcer in your exam, you are supposed to draw. Okay. And second, when you go in the private practice, suppose you don't have slit lamp camera, and if you know which color is meant for what, you can draw it in a minute, and that will help you for documentation as well as to follow up your patient. Lastly, whenever you draw, you pay attention to details, and that will enhance your observation power and clinical skills. So, whenever we draw for corneal pathology, we draw it in two views. First is frontal view and second is slit view. Always, always. Only frontal view will not work. So, in frontal view, what you show? Site of the lesion, size of the lesion, and shape of the lesion. So when you want to show a site of the lesion, you will have to follow clock hour rule. You divide whole cornea into 12 clock hours. Size, you will have to show in 2 meridians of maximum diameter. Suppose you are showing the corneal ulcer, so you will have to show the diameter, or you will have to show the diameter in 2 meridians. Okay? Then shape of the ulcer. Now in the slit view, what you are going to show? Depth of the corneal lesion. Then AC depth, you will comment over here in the slit view. And AC content, like whatsoever, hypopyon, hyphema, you show it here. And lastly, all things related to iris like anterior synecdoche, posterior synecdoche, you show it in slit view. So let's start with the colors. First is black. We show corneal outlines with black. We show contact lens in the form of interrupted line all around the periphery of the cornea. We show scars with black. So depending upon the type of grade of corneal opacity, we use the shade of black. Like this is the leukomatous grade corneal opacity. So we have used darker shades. And in the nebular to macular grade corneal opacity, we are using lighter shades. And even in the slit view, you should also show the depth of corneal opacity, and if there is any thinning, you should also draw it. Now with black, we also show sutures, corneal dystrophies, and corneal tears, and lastly tissue adhesives and foreign bodies. So these things we show with black colors. Now let's come to brown. With brown, we show degenerations, any kind of degeneration, whether it is spheroidal degeneration, or in this case, you can see the arcus senilis. So I have shown arcus senilis with brown and dystrophies with black. And you all know iris and iris pigments we show with brown color. Now let's come to the blue. Blue is for corneal edema. So like in this case, this patient was having epithelial, edema, bulle. So we depict epithelial edema with blue dots. For stromal edema, like in this case, we show it with blue patches. If the patient is having severe corneal edema, like in this case, and having Descemet's folds, we show Descemet's folds with blue lines. And in the slit beam also, you will have to show the thickening of the cornea, and not on the anterior side, okay? Always on the posterior, part of the cornea, you show the increased thickness and Descemet's folds. Now let's come to the red. Red is for blood vessel, hyphema, rubiosis iritis. So superior blood vessels you can trace across the limbus. So that's why we show them with wavy lines crossing the limbus. Deeper vessels, you cannot trace them across the limbus. So we depict these deeper vessels with straight lines starting from limbus. And in some cases of, healed iridocyclitis, old iridocyclitis cases, sometimes we see ghost vessels. So you depict those ghost vessels with red interrupted lines. Now green is for epithelial defect. Any epithelial defect without any exudates, like persistent epithelial defect. So you show it with green. Punctate epithelial keratitis with green dots, and filaments with small green lines. But in cases of dendritic ulcer, we use two colors. So outer line is with red, showing the rose Bengal staining, and inside you color it with green, showing fluorescent staining. Now last is yellow color, and this was a case of fungal corneal ulcer with hypopyon. So with yellow, I'm showing it this infiltrates, exudates, but outline you see I made it with green color, depicting that there is epithelial defect and there are so many exudates, and if satellite lesions are there, you show these lesions also with yellow. But hypopyon you will not show here in the frontal view. You will show it here in the slit view, and you should always mention the height of hypopyon, 1 millimeter, 2 millimeter, and depth of corneal ulcer as well. And if you can appreciate in this picture, there are fine KPs all over the endothelium. So KPs we also depict with yellow color and in the slit view. So that's all I have for this class. If any queries, I'm happy to take.